to audio and video and recordings and baby pictures and pictures from your last vacation to be released for publication. You have been fully informed of your consent and release prior to your participation. And now that your self-test is done, now that your self-test is done, everyone, thank you, it's about ready to get started here. Let's see if I can do this without feeding back. Okay, well that's just not working. that's just bad. Okay, fire me. I'm taking the rest of the summer off.
No, you're our producer.
Okay, that was Dead Man's Curve. Anyway, take it away, Dr. Jimmy.
Hello to you out there. Welcome to EMS Live at Night from high atop the Wells Fargo Tower in downtown Spokane, Washington. To the thousands watching around the Northwest, we're glad to have tonight's program for you. I do want to acknowledge one event this month that's in May. I actually think the formal week is not till the 20th of May, but it's EMS Week. Once a year, there's a week dedicated nationally to those of you who provide EMS to our citizens. And it's a great time to take some opportunity to recognize the people in your own agencies who make the contributions. Today in Spokane, we had our award ceremony, and we recognized people who have made an outstanding contribution over the past year, and it was a wonderful thing. Tonight's speaker, Amber Jones, who's the senior EMS instructor with INHS and advanced DMT as well, and the training officer for Deer Park Ambulance, well, her daddy was recognized as our outstanding paramedic, someone who's been a hero of mine for many, many years. So without further ado, Amber, the program is yours.
Thank you, Dr. Nyan.
Certainly.
All right, so thank you guys for having me and being with us tonight. Our topic tonight is going to be, putting Humpty Dumpty back together again. So basically, I'm going to go over different trauma topics and what are the best way for us to currently treat those patients with current standards, current guidelines, those kind of things. That being said, I do come from a rural system, so I understand that sometimes the book way is not the way it actually happens in life. So all the stuff I'm going to talk about today is off of the national guidelines currently for what we're supposed to be teaching for trauma. So if you guys have any questions or anything, please let me know. I'm well open to that. So starting off, it says, first we need to stabilize his spine, right? So I thought it was kind of funny because there's no spine. So there's your Humpty Dumpty reference for you. So to start, let's look back to the basics. When you're looking at your basic National Registry assessment, pretty much those first steps are the same in every single call. We do them simultaneously a lot of the time. So you're looking at your BSI scene safety, our scene size up. A lot of times that's even from the windshield assessment. You're looking at, you know, if it's a motor vehicle collision, before we even get out, is that scene safe? And like I said, a lot of these things we're going to do together. So then your primary survey, your history, your secondary assessment, and then your reassessment. So those are all the parts of the important parts of the National Registry component when you're looking at the trauma assessment for that. So when I'm looking at scene size up, what am I really looking at? That's where you start with your mechanism of injury. How many patients do I have? A lot of times with medical, we're looking at nature of illness and how many patients, right? Because that can help us with, you know, is it a chemical issue or those kind of things? But mechanism of injury and number of patients. Do I need more resources? Do I need that additional help? Can we page out for that additional fire department or additional response? If it is an obese patient that maybe the three of us can't lift that showed up today, right? So do we need more resources? And do I need to consider spinal immobilization or full C-spine precautions per our local protocols? Again, nationwide, those protocols vary drastically depending on the agency and the medical director that's in charge of those agencies. So we'll really look at some of those as well. We'll talk about a couple of those tonight as well. So I liked this one too, where it said, forget all the king's horses and all the king's men, call 911. That's kind of how it is. Someone falls and he may not be super broken, but this guy's kind of broken. So your primary survey, that's that second step if you're looking at your National Registry test sheets ever. If you haven't looked at them in a while, they've changed. So, but your primary survey is your general impression. What does my patient really look like? Sick, not sick? Do we have to stay? Can we play? Those kind of things. Get your level of consciousness or your GCS. We talked about that today in this county a little bit, how there are some differences in those scales depending on what version you're using. So that system's been around for a really long time, but for most standards, a GCS less than 13 is going to be a critical patient. So that's where you would want to make sure your patient's going to the appropriate facility with that. Looking at life threats and our chief complaint. A lot of times life threats are going to become more important than our chief complaint when looking at a trauma patient. However, you have to realize that a lot of times they get that like tunnel vision on themselves because maybe they see that their foot is broken. They see that angulated fracture in their foot. Oh my gosh, my bone is sticking out my arm, right? But at the same time, they're so worried about that they don't realize they have neck and back pain or that they are bleeding somewhere. So that's our job to not get focused on that. ABCs, you're going to want to manage these as soon as possible, manage those life threats, anything associated with airway, breathing, or circulation, super life threat right there, and recognizing shock. And I think that's one of our top priorities when looking at our trauma patients is catching that shock before we get to the point where we all of a sudden see, whoa, they are now in shock. And then transport priority. Are they a priority patient? Do they need flown? Can we even get a helicopter here today? Do I have the capability of meeting a paramedic en route? All of those kind of things, super important to think about. Then you look at your secondary assessment. So again, that's your head to toe. A lot of us sometimes forget when we're not brand new EMTs to actually physically look, listen, and touch. So we can look and we touch, but sometimes we forget to listen. So DCAT BTLS, again, that's deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling, just in case you needed a recap on what our mnemonic meant. We need to manage secondary injuries as appropriate, not just because we see them, right? We've all heard the term, bandaging to death, or you're splinting to death, right? We don't need our patients coming in looking, like they've got 45 Band-Aids on them because they wanted to Band-Aid every scrape and scrap that they saw, right? So secondary injuries are not as important. We really want to focus on those primary injuries that could become an issue or are already an issue. And then reassessment. I am a vital sign junkie. Most of my probationary members do not like to actually ride with me because even if they are not a critical patient, you're getting a lot of vitals. And that's just because I really enjoy seeing those trends. So again, reassessment is every 5 minutes on your critical patients, if not sooner. If I have somebody that has an airway compromise, you're going to be looking at their airway almost continuously, right? So I'm not going to waste the time to go, okay, well, I'm going to not look at you breathe for a whole 5 minutes and then recheck you here 5 minutes later and hope for the best. Same thing with your circulation, those kind of things. You see those changes once you get those good vital signs. Remember, first set is my baseline, second set verifies that. Third set is where it starts my trend. So usually after that third set, if you start seeing something, or even at that second set, you start seeing something that's a little off, you might be realizing, whoa, something needs changed. Again, reassess your GCS. A drop of more than 2 points usually indicates that that is a critical patient or that they could have a brain injury. So we do need to make sure that we are going ahead and getting them to the appropriate care. And then again, does my patient have new complaints? You have them on a backboard and all of a sudden now their back is hurting and now they can't breathe well. Do we have the straps too tight? Oh, my stomach's hurting. Do you have a strap over that? Those kind of things are what we need to look at when we're reassessing. So when I decided what I wanted to really do with the trauma here, I wanted to talk about shock, specifically in what kind of injuries we could look at in each form of shock, really when we're talking about trauma. So to reinforce that, what does shock look like? So
Let's have someone mute their mics. Check your mics out there. Someone's got their mic on. Please mute it.
alrighty, thank you. No, thank you. So when you're looking at shock, usually what the book definition is the body has lost its ability to adequately provide blood, oxygen, or both to the organs and tissues. So the supply doesn't meet the demand anymore that our body is using. So compensated shock, our body can maintain. Decompensated shock, our body is starting to not maintain. Irreversible shock is the loss of perfusions to vital organs. If we don't catch our patients before they get into decompensated shock, it's easy for them to go into irreversible shock. So that's where those small, minor vital sign changes, those small reassessments, looking at that, that's where we can really catch those signs of, whoa, they're starting to decompensate. One of the great early signs is altered level of consciousness. They start mentating differently. Their heart rate changes, their respiratory rate changes slightly. There you go, we're not compensating as well anymore. Untreated shock is not, majority of the time, going to lead to death. I'm going to say that. It does say shock kills, right? So literally, if we do not treat the shock, our patient is going to go into irreversible shock, and they are probably not going to make it. When looking at the generic, there's like a lot of wide, broad terms for how shock looks. Now, we've probably seen a lot of these, but these are pretty common. So altered level of consciousness, pale, cool, diaphoretic skin, nausea, vomiting, changes in vital signs. They can be very anxious or have that feeling of impending doom. Take that for what it is. If you have a patient that's been in a critical incident and their vitals are kind of crashing a little bit and they think that they are going to die and they're telling you they're going to die, there is maybe a good chance that we need to try to prevent them from dying. So you look at cardiac arrest, like they sit there and they go, oh, I'm having a heart attack. I think I'm going to die. I just can't, I'm not going to make it through this one. And a lot of times those patients are right. They don't make it through that one. So looking at that, if they have that, that's usually a kind of, okay, let's put some more diesel under that and get them there a little quicker. I'm not going to focus too much on a couple of these shock types, but we're going to talk about cardiogenic real quick. That is the inadequate pumping of the heart. So you can get that several ways. An MI or a heart attack, so myocardial infarction or a heart attack. You look at that, even if they're having angina, again, we cannot rule that out as not being cardiac of nature, but if they have been in a trauma, that stress of that car accident can absolutely cause somebody to go into having a heart attack. It puts extra exertion on the body. Their heart's racing. They already have had a pre-existing heart issue, all of those things. So we do need to not rule out heart attack when they have chest pain. CHF, pulmonary edema, can cause that. Bradycardias, again, from usually hypoxias, more so in your trauma setting, but again, you can have medication-related bradycardias, all of those. Tachycardias, again, all kinds of reasons for that. Today's society, we can see that a lot with the Bradys and the Tachys, looking at, drug use, what kind of drugs they've been taking, polypharmacy with medications, a lot of that. And then if they have an irregular heartbeat, such as AFib, maybe it's untreated AFib, and or they've had pre-existing heart damage and the left ventricle has now been affected. So a lot of those issues can look at cardiogenic shock. Now again, you could have a trauma that could lead into a secondary issue because they have one of these underlying problems. Cardiac tamponade is one of the reasons that we could go into cardiogenic shock, though, from trauma. And usually that is a blunt injury to the chest that causes blood to build up in the sac around the heart, impairing its ability to pump the blood out. So what does that look like? Sometimes you hear the words Beck's triad. Again, that's probably in EMT school. We don't really talk about it as much outside of class. However, what does that look like? Well, muffled heart tones. Well, how do you know what the heart sounds like if we don't ever listen to the heart, right? So I get that you may not know that, okay? JVD, when those veins distend, a lot of times the easiest way to see that is our patient laying in a supine position. So looking at that, that's usually a late sign that something's going wrong. And then narrowing pulse pressures, narrowing blood pressure. So again, trending of your vital signs is going to be super important. You start seeing that systolic and that diastolic coming together, that's where you're at. So that can mean an issue. What does that mean? I need rapid transport and I need to treat them for shock. The best basic treatment for BLS responders to treat for shock. We are going to put them on oxygen if their O2 sats are less than, nationally, less than 94%. You are going to titrate that hopefully somewhere between 94 and 99%. That's what our goal is. Now, some of your patients may not ever get there. Also, the best way is position. So if we can lay them down, if their condition permits and they're comfortable, if you're having a massive heart attack and they may not want to lay down, or if they have CHF, they may not want to lay down. But do the best we can with that. And then cover them up, prevent heat loss. That's huge. And a lot of times I think even in winter or summer, we forget that because, oh, it's 100 degrees outside. But if they're cold and they feel cold and they're diaphoretic and all those things and they're in shock, we need to keep them warm. So, and then rapid transport, get additional care coming to you. Neurogenic and distributive shock. What you're looking at with that, we're going to talk here about sepsis, spinal cord injury, and anaphylactic reactions. Those are neurogenic and the distributive type shocks that we usually can see. So with the spinal cord injuries, this one definitely trauma related, right? So I did say we would talk about it a little bit. So spinal precautions per your protocol. Does that mean they can have modified C-spine? Does that mean that every single person that has neck, maybe falls and elderly patient that falls over their walker needs to be in a full C-spine because they bonked their head on the way down, right? All of those things we need to think about. But again, it's per your protocol on what you're doing. A lot of agencies out there have super awesome air vacuum splints that do the full body. My agency does not have that. So, we are a little picky on, sometimes who we are putting on a solid long spine board now. But there's definite protocols in place for us to be able to say, yes, they need a full C-spine, or no, they don't. What I'm looking for in that is always making sure that you're getting your sensory, motor, and sensation. We used to call that, and when I went to EMT school, PMS, right? Pulses, motor, sensation. Well, they changed that. So
I understand.
CMS, right? So circulation, all of those kind of things. So that includes every extremity. And I think sometimes we forget this as well. You need to do right hand, right foot, left foot, however, whatever system you have for that. But you should be doing each of those limbs independently. We shouldn't be going down both sides at the same time, even when doing those head-to-toe assessments. This does include pulses, skin, color, temperature, and condition. And a lot of times we forget that last part, the two last parts, temperature and condition. So color we get, right? They're pale, ooh, not good. They're gray, ooh, not good, right? They're blue, not good. All of those, we get that. But then we forget to feel, are they hot? Are they cold? And if I forget to actually feel that, if we're looking at a spinal cord injury, a lot of times you're going to see a temperature change above and below the injury. So one portion will be warmer, one portion will be cooler. Usually the portion below the injury is where we're actually going to see more of a warmer temperature, and then the temperature of the skin above the injury is where you're going to see that cool, pale diaphoretic, right? We see, oh, shock, cool, pale diaphoretic, whoa. And then we forget to do the rest of the assessment because we're treating for shock, okay? Appropriately sized C-collars. Yes. How do we do that, right? Well, it really depends on how you, what model you have, what versions you have. Probably the most inconsistent thing we do is appropriately sizing the C-collar, not allowing the patient to move and wiggle back and forth all the time when we're putting that collar on, making sure that it's mainline. I can see the trachea. I can see all that when I have that C-collar on. It's not crooked. And also, please don't pad underneath the C-collar on one shoulder, those kind of things. I've seen a patient come in and their head's seriously cockeyed because they got a huge trauma bandage underneath the C-collar, and I'm like, couldn't we have thought of a better way to do this? All right. Also, if you cannot move the head back into a neutral position or midline position without that hurting or making crunchy sounds or things like that, please don't force it back into a neutral position.
Crunching sounds.
Too far forward, too far back, any of that, really not good, right? Definitely padding voids and padding underneath the patient is one of the things, I think, underneath the patient is one of the things we always consistently forget. And then rapidly transporting to appropriate facility. You know, I'm going to say definitely if you have a trauma facility in your system, that would be the place to go. However, I do understand a lot of us go to a critical access hospital where they get stabilized and then they transfer out. That's perfectly acceptable. We just want to do the best care we can while we have that patient in our system, right? So CMS before you put the C-collar on, after you strap them to anything. And that includes a CAD, that includes backboard, anything like that. So before and after, and I'm even as picky to go, okay, we did that before, they're done now after. We've loaded them onto the stretcher, we put them in the ambulance, and then I reassess CMS again because I've moved them twice since I last did that. So it's kind of like verifying tube placement in a way, or a king tube or whatever supraglottic airway you're looking at. Every time we move them, we need to re-verify. So that's where I also do my CMS, okay? So the national standards for spinal motion restriction, this is the recommendations after September 1st, 2016. So it does say it should be considered to include individuals who have sustained blunt trauma through high energy mechanism and any of the following. So again, this is the national standards. It's either adopted in your area or not adopted based on the state and the area and the medical directors involved. So if they have altered level of consciousness, if they are drug or alcohol intoxication, that does include the legal marijuana in our states. That's kind of a, how do you tell if they're truly intoxicated or not? Well, if I don't know you and you appear intoxicated to me, I may have to call law enforcement to say, yes, they are impaired and they need to go. But that's what we need to do to sometimes protect ourselves and our patient. If they have the inability to communicate, and that does mean our special needs patients as well. Some of them are not able to tell us how that really hurts. If you look at a pediatric, a young pediatric, that's been in a car accident and maybe their parent is not conscious, but that kid is scared to death. They are not going to want to maybe talk to you. How are you going to get a good assessment out of that? If they do have spinal column pain and or tenderness, so again, you're going to want to make sure you not only ask, but we need to touch, right? So a lot of times we go, hey, does your neck or back hurt? Because it was just a minor fender bender, right? We know it's going to hurt in a couple hours and all that stuff. We get that. But we forget to touch. And then you start to palpate down the spine and you hit a spot about mid umbilicus, belly button area. And they're like, ow, that hurts. Well, that didn't hurt 2 seconds ago when you just told me that you had no neck or back pain, right? So those kind of things. If they have neurological complaints, such as numbness, tingling, weakness, I don't care if they have been sitting in that car for, 4 hours before they got in their car accident, and we did not have to extricate them, and they think maybe their foot's just asleep. I don't care. That is a neurological complaint, and that is something that we should probably take into consideration before we move them. Anatomic deformities of the spine, obviously. Please don't try to push them back into position. So we're going to want to pad in the best position we can, and sometimes that is difficult. And then if they have a distracting injury, so injury is so severely painful that the neck examination is unreliable. Example, they have like an arrow sticking out of their chest or something, right? They're going to really not care that their neck hurts. They're probably going to be more focused on, I have this arrow in my neck, can you get it out? Right? Or I have this stick that's impaled through my leg, can you get it out? Our answer is no, right? But honestly, if they have any of those things like severe thoracic trauma, long bone fractures, they've got bilateral femur fractures. We know that that's a general concern for pelvic fractures and all these other things, but they're really concerned that their legs hurt really bad. I get that. So that backboard or that neck and spine assessment may not be correct. Okay, and large burns, especially if they have a lot of secondary degree burns, they're going to have extreme pain with that and not tell you that their head or neck hurts. Okay. Those are the shocks that I'm not going to talk about like as much because we kind of are going to get into some of the other ones that have cool pictures with these now. So my hypovolemic and hemorrhagic shocks, those are the two that basically the same thing, right? Blood loss causes volume issues and all those stuff. So we're going to talk about burns, bleeding, and crush injuries. Technically, by book definition, what does hypovolemic look like? Systolic blood pressure less than 90. Again, that's patient dependent though. We all know those people who are always right around the low 90s systolically, and that's just where they live and they're happy with that. And 86 is no big deal. They're not dizzy. They can stand up. They can run still, all of that. But for the majority of the population in the adult world, a systolic blood pressure less than 90 is going to be hypovolemic. Do they still have peripheral pulses? If the answer is no, we've got a problem somewhere, right? And then bleeding, you can see. That actually I wrote color, flow, location. Makes a difference. What color is it? How fast is it coming out of them? Is it squirting? That's a big problem, right? Is it dark? Is it bright red? Is it, got weird colory chunks in it? All of that kind of stuff makes a big deal. And where are they bleeding from? If they are squirting from their neck, I can't really tourniquet that. So that makes another issue that I have, right? So location's huge with that. So here's my pictures. I told you pictures, things that we can do BLS wise. All right. So arteries usually has spurting or squirting. I call that my ketchup bottle, like exploding type bleeding, right? It's in the horror movies. It sprays everywhere. That's the one we're looking at. That one has a pulsating flow usually, and it has a bright red color. Our venous bleeding is a slow, steady flow with a dark red color. Now, venous bleeding is usually not as, I say usually, not as dangerous as if we have arterial bleeding. Arterial bleeding is a life threat now, right? Like I fix that now. Venous bleeding, depending on where that location is and how much they're bleeding and all of that, that may not be a life threat right now. So that may not be as important. And then capillary bleeding, again, that's like a scratch or, you get a paper cut, those kind of things. That's a slow, even flow. I don't even worry about that, okay? However, capillary bleeding on your face has a tendency to look like it's venous bleeding on your face and head because it is so vascular. So a lot of times you're going to see a lot of blood with that and you just wipe it and there you go. It was like this tiny itty bitty scratch and they're freaking out for a tiny itty bitty scratch, right? Direct pressure. It is one of the best things we can do, and sometimes I think it's the last thing we really thought about because somebody else was already holding pressure. But if that's not you as the EMS provider that's holding pressure on that, I'm going to guarantee you they're not holding the right pressure because direct pressure doesn't actually feel good, right? I'm not saying stick your fingers in the hole because we don't want to do that, but direct pressure is hard pressure and it takes a little bit for that bleeding to stop. Okay. Again, tourniquets in the bottom, you can get all kinds of tourniquets. I don't support one better than the other. I'm a big fan of you use what you got. So I've seen people take their belts off. I've seen sheets made into tourniquets with a screwdriver. Did I take that off? No, right? Because it worked. Why would I remove? I'm not going to remove something that's working just to replace it with something that looks brand new, right? So no. Other things, O2, right? Again, if they are bleeding and they're hypoxic or hypovolemic, we're going to want to provide some oxygen. Even if that's just a low flow, like just 2 to 4 liters nasal cannula, sometimes that just brings that anxiety level down a little bit, especially if they're tending to hyperventilate over the fact that they're having a little capillary bleeding and they don't like the sight of blood and they can't stand that. If you do have the availability of an advanced or IV techs or paramedic level, IV access, usually for anybody that has a significant bleed, is probably going to be a great idea. With that being said, any of us that have been in this for a long enough period of time know that if you end up putting about, a little bit more than 2-3 liters of saline into somebody that's aggressively, actively bleeding, It starts to look like Kool-Aid when they bleed out of that hole that they're bleeding out of. So we really need to make sure that we're not making our patients Kool-Aid as well. If you're out in the field and you're having that much bleeding, we need to look at rapid transport if I do not have additional care coming to me. At that point, we're doing the best we can to provide for our patient. But if you think about it, saline doesn't oxygenate cells. Kool-Aid does not oxygenate cells. So when their blood starts coming out and you notice that it's super watery and it's not coagulating on the highway that's 110 degrees anymore, that's usually a sign of a problem. So just be aware of that. Not every patient that's bleeding requires 2 large bore IVs running full wide open. You know, we don't necessarily need that in every single patient. So, but that's the old school theory. When I started, that's how we did it. Every trauma patient, they were bleeding, they got 2 wide open, large bore IVs, right? Get them to a trauma hospital within that hour. That's our goal. Not realistic all the time. Looking at burns, again, burns can be anywhere from not trauma to trauma, right? What makes it a trauma? That's where we have to determine what kind of level of burn, where's our patient going, what needs to happen. So first thing first, if they are burning still, put them out.
Excellent.
Right? That's number 1 rule, right? I'm not a firefighter on purpose. I will probably yell at you to stop, drop, and roll. Okay? If you don't listen, I don't know what to do because I do not carry a wet blanket in my ambulance with me. All right? So put them out, remove any burning and smoldering clothing. Try not to burn yourself. That's my goals, right? I did put remove any jewelry as necessary. So rings, necklaces, anything that would possibly be in a potential area where they're going to swell, that needs to come off because otherwise they're going to lose it anyways, right? And I do not care if that's my grandmother's ring that was handed down 45 generations of people, right? If my hand is going to swell and it's going to cut that circulation off anyways, that ring's got to come off. All right. ABCs, oxygen is needed, consistently reassessing airway, especially if that burn involves anything with the nose, mouth, face, airway at all. Because if you think about the first thing we do when we see a ball of fire coming at us is go, right? So I don't want to do that, but we need to reassess. We start hearing any airway issues, stridor, mucusy, wet, anything like that, that's a huge sign that I have a problem. Estimate the severity of the burn. And again, that can be used by using the rule of 9s, depending on your patient, or you can use on smaller surface areas, you can still use the rule of the palms, which is the patient's palm, not your palm, is about, anybody know what percentage of BSA that is? Anybody anywhere? How about anybody in Washington?
1%.
That is right, 1% of the BSA. You have to use their palm. I do not want George, who works on the ambulance, who is the biggest guy I've ever seen in my life, because I know there's some of you out there up north that are like really big guys that have hands that are huge. I don't want you using their hand on like a little tiny old lady, right? Okay, so because that would be like 3 of her palms to make your 1 palm, all right? So you can use that on smaller surface area burns. Again, severity also makes a huge difference on where I need to go if it involves hands, feet, face, or genitalia. Most of the time, most of our burns, we're not going to be really asking somebody, you know, hey, is your genitals burned? They're going to probably tell you, okay? Hey, everything down there's burned, right? Or if it was circumferential on the legs and the thigh and the torso and everything, I'm going to guarantee you they're going to be trauma naked for me in 5 minutes anyways. But looking at that too, you know, really, it's hard to assess how bad that airway was burned if they have any facial burns, because sometimes it's going to look okay right in the mouth, but the back of the throat's been what's burning. So again, please just reassessing that airway, listening with your stethoscope on the throat. A lot of people can forget that. You can hear airway noises in the throat versus just in the chest. So thinking about that, you can tell if it's stridor up in the upper airway or down in the lower airway. So all of those kind of things. It does say cover with a dry, sterile dressing. Okay, that's the generic rule of thumb for most things, making sure fingers and toes are separated out individually so they're not stuck together looking like a Ninja Turtle by the end of the time that they've been with you. Treat them for shock. Most importantly here, prevent heat loss. They're going to be cold, especially if they have large surface area burns. And if you have your IV techs or any of those available, preventing fluid loss because they are going to start to lose fluid, and transport to the appropriate facility. Circumferential burns, we need to be a little bit more careful with when we're wrapping them and transporting them. If you've ever dealt with a circumferential burn, you're going to look at the potential for significant swelling at a cellular level, and that can happen pretty rapidly. That skin can actually start to slough off because the whole entire area is so wet. So please make sure you're providing a little extra care and not handling those patients too rough. I know time is of the essence, but really making sure we're not causing any skin tears or anything like that that aren't already there. And we're just doing the best we can to treat our patient. One thing I personally have not seen a lot of, I think some areas might see more of this in like farming areas or where you're working with heavy equipment a lot, but it's crush injuries. Again, this can cause hypovolemic shock or hemorrhaging, so that's why it's in here. Excuse me. Compartment syndrome, we've heard about that, right? Probably a long time ago. We haven't revisited it in a while because I sit through every one of these EMS Live at Nights and I haven't heard about that one in a while. So what does that look like? Well, what is it? It's tissues and vessels, or one of both, are constricted within a space from swelling or too tight of a dressing. So it can actually happen if we put on a tourniquet, right? Because that dressing is too tight and everything below that is going to start to swell. It causes tissue and cellular death. That's why if there is a crush injury, we're looking at the potential for our patient to become septic or be acidotic, respiratory issues, clotting issues. They could throw a clot and get a pulmonary embolus. Any of those things that we have when we are removing an object from someone who has been crushed for a significant amount of time. So, why does it matter? Because the fractures of the crush causes bleeding and swelling. So they're hypovolemic, we know that, that's great. Can I fix it? Probably not without surgical intervention. How fast can we get them to a hospital once we remove the thing that's like causing their arteries not to bleed out onto the ground? Right? And we had a example here not super long ago with our gentleman that was in a truck accident a semi-truck accident, and literally had to be cut out and amputated his leg out of the truck to get him out by a surgeon that they took to the vehicle. Well, that's not normal, right? But there's no other way we were getting that guy out. So that's what you have to think about. What can we do? Well, you need to treat him for shock, number one, right? I sound like a broken recorder, treat for shock. But in everything we do in trauma, we treat for shock. So the other things you can do, grab an EKG. If you can even get a 3-lead, that's great. It shows us already if they're having cardiac issues or enzyme issues, or usually not enzyme issues, but cardiac changes, electrically changing, anything like that. Splinting, can we splint things? Do we need an IV? Can we get a rapid transport? Do we need to tourniquet? The gentleman on the highway here, they put 2 tourniquets on prior to that surgeon arriving, above that injury. When I said don't splint to death, we do not want to bandage and splint to death, okay? I loved this one because it really defined the do not splint to death. How she's like, it's ready for transport. And he's like, all mine did was smash my finger. Okay? I have seen someone come in on a backboard and they look like a mummy because they've got both legs splinted and both arms are splinted and they're on a backboard. Did we really need to splint they're unconscious on a backboard. And they've got every arm and limb splinted individually. Did we really need to do that? Probably not. Okay, we wasted a lot of time on scene Or in the back, we had a lot of extra hands that didn't know what they were doing, or what to do. Oh, we should just splint that because we have time. Don't worry about that. Don't do that, okay? When we are splinting fractures, you want to make sure we don't have them too tight. So how do we know we have them too tight? CMS before and after. I want to make sure I have pulses, motor, and sensation prior to and after splinting. If I don't, I need to readdress that. If I do have it at both, and then all of a sudden they're like, my fingers are throbbing and it feels like my hand is going numb, I need to loosen that splint a little bit. If no injury is found with CMS, if injury is found with CMS, then we treat it. If it does not have the sensory, motor, sensation, whatever, and your protocols allow, you are able to usually put that back into an anatomical position if possible. That may not always be possible, okay? I am not telling you to pop an elbow back in. I am not telling you to pop a shoulder blade back in, okay? We are not doing that unless that's in your protocol, not in mine. So I'm going to splint and transport. A lot of times we try to splint in the position of function. Again, something not everybody has heard since EMT school. So if you're looking at that, what does that look like? Well, I don't want my toes extended pointing to the ground like a ballerina on the backboard, right? I don't want my knees to be flat against that backboard. We need to have a little bend in that, especially if you're splinting a leg. Put a pillow under there, make it comfy, like have it in a nice position. That's why casts, a lot of times their fingers are rounded around the end on those casts because they're not wide out just like a spider web full out there. Like they've got to be in a position of function, preferably, especially if they're going to be in that for a long time. Couple quick pictures of fractures and splinting. I liked the guy with his ankle hanging out, foot going the other way. That was not good. How am I going to splint? I'm not putting that back into a natural position, right? Traction splints are great. Think about how you're going to get that into the ambulance. Michael, don't look at that one. Sling and swath, something we don't practice that often a lot of times. And if you don't practice it in practice, you can get on scene and look pretty silly trying to make a patient get a sling and swath if you haven't practiced that in a really long time. You're like, how come this isn't working? Right? Something to practice. Okay, better. Abrasions, we're going to talk real quickly through my open wounds and stuff. Abrasions are scratches and scratches. Clean out any debris. Usually don't even need a Band-Aid, really, okay? Avulsions, tearing away or a flap of skin. Usually we want to clean that area, and if it's still attached, kind of just put the skin back on there, kind of like a Band-Aid, and then bandage around that, all right? These ones do say with avulsions to wrap with a moist dressing. That way the skin doesn't dry out. Now notice it didn't say soaking wet, soaked in water, dunk them in water, and then put it on there. Moist dressing, please don't use the gross lake water. Let's put some saline on it and then do that, okay? Amputations, you may not want to look at this one. Surgical or traumatic removal of a body part. If it's gross and it's bleeding severely, apply a tourniquet. Treat them for shock and rapid transport. Here's the key with these. You got to take the part with you. If you can find the part, you got to take it with you. It does say write the patient's name on the bag with the part in it, okay?
Let me give you a hand.
I'm not exactly sure how many parts we're talking about from different people here when they created this, and I think it's probably more mass casualty type incident. But unless you have multiple patients you're transporting with multiple different fingers, usually the guy missing his fingers is the only guy in the ER with the missing fingers. So you may not need to write the name on the bag that you took it in with. But I'm just saying it's usually a great idea to transport that with the person. If they're multiple fingers from multiple people, maybe try to match the skin or the fingernail polish. I don't know. Do your best, right? But there you go. A lot of times now we are able to reattach amputated parts, especially if it was a clean amputation or those kind of things. Our surgeons are getting really good at that. Another thing, do not place it. It does say that you should put it hopefully wrapped in a sterile dressing in a baggie that is tight, airtight, and then put it in a bag of ice water. Notice I did not say please put it in the beer cooler that has all the ice water in it without it being in a bag, okay? Because that actually ruins that tissue and then they're not able to replace it. But if you can, even if you wrap it in somebody's t-shirt, put it in a bag that is not full of water and that cannot get wet like that, and then put it in that cooler, fine, I'll take that. I'm taking your beer cooler with me to the hospital, but there you go, okay? Rapid transport though. Lacerations, those are cuts. It's totally not gross now. They treat, it's not gross. Treat based on severity and the type of bleeding for our cuts, but a lot of us know that a lot of times, you know, oh, you cut yourself, great, don't do that again, right? So it's not that bad. That's usually not what they're calling 911 for. But again, I've been on a stub toe, so I put it on there. Punctures. Objects tear through the skin and destroy the underlying tissue. Do not take stuff out unless you have to, because it's impeding CPR or airway and breathing, okay? Manage the bleeding, stabilize the object. You may have to have, like some of you guys I know work fire and on the ambulance and all that together, and you get to play with cool tools that cut things apart. You might have to be creative how you're gonna get your patient to the hospital with what they have sticking out, okay? So again, stabilize, don't pull it out, okay? Open wounds are perforating traumas, and that's trauma associated with an entrance and exit wound. So a lot of times people don't understand what perforating means, so that's what it means. You need to stop the bleeding, number one, because that's usually going to be in some kind of cavity, right? If it goes in and out, the biggest part of our body is, looking at it mass-wise, my thoracic and my abdominal cavity. That's where I'm super worried about when people get shot with larger caliber 22s, those kind of things, depending on where they were shot at and at the distance. Good luck figuring out what that hit internally. So you might have to actually be looking at that as a wide-scale, full-body trauma assessment so that you're looking at that. Don't stick your fingers in the hole, okay? I know that, like, if you've been in the military, sometimes they teach you that. We're not doing that. Please don't stick your fingers in the hole, okay? Watch for compromise and change in respiratory status and vitals, because if you have that, you may need an occlusive dressing. Usually lung sounds are diminished, and they are very common. Tracheal deviation and JVD, again, is going to be a late sign that we have that tension pneumo, that hemopneumo, any of those kind of things. So definitely make sure that they have an open, sucking, gurgly chest wound, we want to put an occlusive dressing on that. I don't care if you take a Ziploc bag and tie that down because that's all you got, okay? But put an occlusive dressing on there to stop that. Look at that, I'm doing really good on time too. So, recap. Just kind of, again, I did some basic trauma topics just to try to get us reacquainted with some of the things that we really should be looking at. Do not splint to death, please. Don't get sidetracked. Make sure that when you're looking at that full head to toe assessment and you see that broken ankle, and yet, you know, maybe we're missing that they have a flail chest on one side because he's like, we can see that ankle bleeding. Oh my goodness, that's not the part we need to be worried about. Use your resources, whether that's additional resources from your own agency. Do you need to call in an agency that's neighboring you that you might have a mutual aid agreement with? Do I need a life flight helicopter, or do I need some sort of additional resources? And do the best we can with what we have. Because I know that there's a lot of agencies that join us that we don't have, you know, levy-based funding. We don't have the newest, greatest, and coolest equipment that's out there and breaking and all of that stuff. I have seen a splint with duct tape. Okay? I know it's not the best tool, but there we go. That's what we got for the day for where we were at, right? And it's not pretty like on TV. Sometimes we don't get to carry our full entire box of all our cool stuff to where our patient is at, especially in those rural areas. So do the best with what you have, and golden hour. Try to get our patients there as soon as possible, and please recognize shock. That's probably the most important takeaway from here today, is recognize those signs and symptoms of shock. Does anybody out there have any questions?
Perfect. Amber, that was wonderful. That was a great presentation. Boy, and I've been around quite a while, and I get to ride ambulance once in a while, and fly once in a while, and also see patients treated. The fundamental approach of patient assessment, a comprehensive assessment and reassessment, that's part of your history, I know, is so important. It's so uncool when you drop someone off and they're tanking and you didn't know it, and appreciate that fact. And I think your diligence and your initial assessment and reassessment of the body and shock and the extremities regarding do they work is hugely valuable. And the earlier you pick that up, the sooner the hospital can set in motion the mechanisms they need to adequately treat the patient in time to do something before the injuries are reversible. And you address that just beautifully.
Thank you.
As far as I know, and I don't immerse in EMS as much as you, that's contemporary, state-of-the-art training regarding trauma treatment. And that was wonderfully delivered.
Thank you.
I do want to recommend, one of the big issues in our state is that people my age, our biggest cause of major trauma is Washington. People my age and older fall down and bang our noodles and break our hips or pelvis, but also get bleeding on the brain. So beware of that patient. They're working on adjusting what we call our trauma triage criteria in the state to say, think if they're over 65, you got to be more careful with them. And an important question, if you can get that from the patient or their family, and to tell the hospital, are they on blood thinners? So if they're on blood thinners, make sure you apply that to information you provide to the hospital when you communicate with them. Another thing in your future, as you go forward and you're continuing on about trauma, one of our most important missions, look up a Google search or search Stop the Bleed. Stop the Bleed. It's a national campaign that is being introduced locally and taught locally. It's somewhat an unfortunate consequence of this time we live in, but the idea is to have every citizen capable of taking measures to control injury in their schools, in their workplaces, similar to what we've attempted to do with CPR and AED use. Where we want to empower the citizens to, if their buddy gets winged, shot, something bad, they know how to do a few basic things. So Stop the Bleed is something you should take a look at. Great presentation. On to our questions. You get to call on the state to answer each one.
Ooh. See if I can answer my own test questions. How about that? I'm just kidding.
Oh, you can do that. You don't get to. It's the state's
All right.
get to.
So let's see.
We got Washington, we got Montana.
So Montana, let's start with Montana, because Washington already got called out earlier today. So anybody in Montana, which is not part of the primary survey?
Chief complaint.
A, chief
Sorry.
complaint.